part of my talk is about prostate apex, its anatomy and variations. So these are different anatomic variations of apex. So you should be careful about, don't look at the prostate shapes. If you look at their edges, all of them are different from each other. So we have to be very careful when we are doing an apical dissection of prostate. It's very important. Every individual have different prostate shape. The apex may overlap the urethral sphincter circumferentially. It may be bilateral symmetric. It may be asymmetric one side. It may have anterior overlap, posterior overlap, and etc., etc. So Lee et al., they did a study, very good study. They found circumferential overlap over the urethra with prostate in 38% of patients. He saw anterior overlap in 25%, posterior overlap 22%, no overlap only 15% of cases. What does it mean? It means you will see a significant part of your patients overlap, 85%. So we have to know the prostate anatomy very well. If we have a circumferential shape like this, it's easy. How many of you have seen such a prostate shape, like these two bones? Wow, excellent. Everybody, okay. I had one. Like this. In this case, you will see a little bit horn. If you can make a comment from the panel, I will be happy. So you will see a prostate shape, like a horn from two sides. What I believe always, we have to take our time when we are doing an apical dissection. We are not racing with time. We shouldn't cut, and the patient will be incontinent or rising PSA after the surgery. We should take our time. If there is any bleeding from dorsal venous complex, rise the pneumoperitoneum. It doesn't make any difference, what I believe. So it should be a bloodless field. We are doing an oncological procedure. So you will see the urethra goes inside of this part of prostate. Look how the right side goes up to here, but the real urethra is here. If you are going to cut here, I will show you what will happen in this patient. So you should make a S-shaped turn in this patient. The patient has one chance. He will be continent or incontinent. So I think we have to take our time and do it very slowly. We are not racing with time, what I believe. You see the bulging part of the prostate. Yeah. I put these old diagrams to John Davis. He was the editor of our book. So if you see the deep part of the prostate, if you see the edge of prostate, you were going to cut from here. How many of you were going to cut from here? Nobody? That's fine. So if you cut here, you were going to sacrifice this amount of urethra. Maybe the patient will be incontinent. If you go to urethra and cut from here, this part was going to stay inside the patient, and the patient will have a rising PSA. It will say that, well, I don't understand why this PSA is rising, because you left some part of the prostate inside the patient. And this is the final specimen of that patient. Everybody, people, they are seeing such kind of prostate, but it was very interesting for me. Right side was the dominant side. Another different example for apical variations. You see the urethra is here. This is the left neurovascular bundle. This is the right side. And there's a BPH nodule on the right side of the prostate, if you look carefully. You see how it protrudes. The urethra is going to be finished here. Now, do you think that we can see these anatomic variations in posterior approach? I always think about it.
Yeah, I think yeah, you can see from lateral and posterior.
But you can see the anterior side first.
Anterior, so you have to go under the dorsal vein.
Okay.
You kind of watch Rod too. It comes around the side, and you can see it's different from the side. You can get some of the anterior fluids on the side.
Side view.
See here how nicely you rough those nerves off. They're really hanging off. And it's not always easy to do or able to do, but I think the key features, you said, slow down, move slowly, identify your structures, make sure the nerves are off. And I always like to say, bring the catheter, kind of like that jiggle test. Make sure the catheter is in and take your time to delineate where you are to optimize. Now, patients with high volume prostate cancer at the apex, will be as aggressive on the nerve at the length.
Sure.
What are your comments on that? Would you go for A or for B if I have at least a 9 on my apex? So we all talk about the length and so forth. Do we do any kind of variation for disease at the apex or topical nodule at the apex?
A&1.
A&1. Where the asterisk is.
Okay, in this patient, if you are going to cut from A at the end of the prostate, you are going to sacrifice this amount of urethral length. If you are going to cut from B, just to make the patient continent, this BPH nodule was going to live inside the patient and will cause rising PSA. So we have to keep in mind, we have to see prostate anatomy very well and very detailed, and with a bloodless field just to see the difference. So it's demonstrated that when the prostate parenchyma covers the urethra on anterior or posterior side, there is risk of great excessive shortening of the urethra. It may go from posterior side or sometimes from anterior side of the prostate. Just in this case, can we stop it and ask questions? Yes. How many of you see the prostate is ends here, how many of you were going to cut urethra from here? Could you please raise your hands? Yeah, most of you. Okay, let's see. Where is the urethra?
I think most people would, from a two-dimensional view, will look at the shoulders where your monopolar is.
The prostate has shoulders on both sides. If you look at carefully, you will see. If you are going to cut from here, now you will see the urethra goes up to here. So you were going to sacrifice a great part of the urethra. You see, the urethra goes until here. These are shoulders. You can take the urethra inside the prostate and make it have a longer urethra. Like in this diagram, you will see, if you cut here, you are going to sacrifice this part of the whole sphincter. And you should make it, but you should do this in low-risk patients. If there is no apical tumor in the patient, you should do these techniques. If he has high apical tumor, the oncological safety is the first. You shouldn't do this, I believe. And the last part of my talk is prostate apex and urethral sphincter. As you all know, urethral sphincter has two parts. First is external rhabdosphincter. The second part is internal. It's smooth muscle. We have to keep this in mind. Everybody thinks that the urethral sphincter begins after the prostate. This is not true. Because if you look at embryonical cases, the urethra is covered by the prostate. And the important part is located inside the prostate, a significant part. So we have to keep in mind that. So the prostate goes from urethra and starts to cover it from embryonically. So that's one of the most important parts of histological development. What we do in open surgeries, this is a publication from Martini Clinic, I think. So in open surgeries, they do dissection inside the prostate in order to have a longer urethra. If you have a long urethra, your patient will be continent. What I believe, the urethral length is one of the most important points to have a continent patient. So it's easy. So is it possible to do this in robotic surgeries? Yes. I'm trying to do in my patients in low risk. This is one of my patients. So you see external sphincter here. No need to cut from here. There is internal part going inside the prostate. This was a very low risk patient. He had only one tumor on prostate base and no tumor on apical side. By doing this blue arrow side, you protected this much of urethral length in patient. This patient is totally continent, not even a single one drop. This is the part, and after the surgery, you can see the urethra. And thank you so much.
Audience. We have one more quick session that I'll do on reconstruction.